Okay, great. Well, good morning, everybody. It's Melissa Andrews, President and CEO of LeadingAge Virginia. I'm standing in for Dana today. So thank you for being here. First, we just wanted to remind you that registration is open. We will miss being together again. I recall 2 years ago when we were actually able to be on Capitol Hill together. We had the largest LeadingAge Virginia contingency that we had ever had. And how much fun it was to be together advocating for our members and for those you serve. So I hope that you will register today. I'll put the link in the chat box. This is a free event. You will be led by Dana and me and others who have gone before, but it's an incredible opportunity to have our federal lawmakers hear your voice. So please, I'll put that link in the chat, and I hope that you will register today. We're grateful that we have some awesome presenters this morning. Craig Cms is back from the Department of Health to talk about the Vaccine Bridge program. We're thrilled that Michelle Ames from our Platinum Elite sponsor, Pruitt Health, is going to talk about their experience and what it has been like providing pharmacy services for some of our members. And back by popular demand is Jody Igor from LeadingAge National, who's going to talk to us about the big rollout that came out of LeadingAge and ACA on Monday of this week. So remember to put your questions in the chat. I'll be monitoring those. And with that, I'm going to turn it over to you, Craig, to get us started. Thanks for being here.
Sure. Glad to be back with y'all today. I had included this slide about a general vaccine update. I know Mike Magner had spoken with y'all before, and he has kind of a more overarching look at the overall COVID-19 situation with VDH. I did attend a morning briefing for local health district directors this morning. Of the information there that I thought may be relevant, the only real significant piece of it had to do with the community vaccination centers you've been hearing about. They are planning to operate the initial community vaccination centers this week in Danville, Portsmouth, and Colonial Heights, starting on the 15th, 16th, and today the 17th, which, so some of those should have already begun. There are additional planned community vaccination centers for Prince William and then Suffolk and Wise beginning on the 22nd of March and then the 6th of April. And these all operate in sort of what's called a closed pod system, where scheduling is handled through a new platform called VASE, and then registration and administration data is produced and created on site. And so wanted to share that information if it has relevance for the communities that you all operate in. If we go to the next slide, we can dive into this bridge program. You'll remember in probably multiple avenues you've heard now about this bridge program in the last couple of weeks. This bridge program is the health department trying as hard as we can to meet ongoing needs for long-term care facilities in the wake of the CVS and Walgreens clinics. There's really two broad strategies here, and I want to give you an update on both. The first is to work to meet ongoing needs, and we continue to work through Pfizer second dose needs that we know are past due. I will tell you that this has caught me off guard with how difficult it is. I can't send a pharmacist into a facility with a vial of Pfizer that has 6 doses in it and only dispense 1 or 2. The logistical challenges of ordering 1,170 Pfizer doses to meet these small needs has been far harder than I expected it to be. Because of that, we have pivoted just in the last 72 hours to begin appealing to local health districts to assist us with these needs. We have satisfied a fair amount of these needs so far, and we will continue to do so. Fortunately, we have had some pretty good collaboration with the health districts. I have called 13 facilities myself just this morning to follow up on Pfizer second dose needs that we realized would be overdue. Thankfully, in many of the cases, they have been met through another avenue, but in some cases they haven't. The only thing I can do there is assure you we haven't forgotten and we haven't given up yet. It's just been more difficult than we anticipated. Our Moderna series starts should ramp up through the week this week and be taken care of in mass next week. We're not going to get to all the facilities next week. When we talk about strategy 2, I have some good news for those ongoing needs. One thing I can tell you right now, if you want to be well prepared on this, is to prepare a list of the staff that you have that have these ongoing needs for Moderna series starts or staff that need to get the first dose of the vaccine. Don't send those lists to me. But when we call on facilities, we have the ability to help work those staff into community vaccination clinics and other clinics that the health department or other partners may be operating. So if you have that list on hand, it will make you best prepared to communicate with myself, the health district, or one of our pharmacy partners who may reach out to you. And I have found several facilities that I've called that didn't have that list at hand. And so that's one thing you can do now to be as ready as possible when we call. There's a really important note that, and actually this is the first time I'm mentioning this in public, and so I'm really interested from the LeadingAge member perspective how this lands. We're in a spot where we're really strongly considering telling CVS and Walgreens to stop offering first doses of that Pfizer vaccine at their third and final clinics. We're encountering something that several other states have encountered, where it's so resource intensive, it's next to impossible to follow up with those second doses of the Pfizer product. I know that there will be facilities that will have staff and residents who may have been anxiously awaiting that third and final clinic to receive that first dose, and I'm certain that this that this news that we're entertaining this may cause some displeasure there. We do have the ability to get the Moderna product and start those series as rapidly as possible to try to minimize any of those delays. Again, on this call, I'm not prepared to say that we're going to give this instruction to CVS and Walgreens. It is something we are strongly evaluating right now. We have a meeting with CVS and Walgreens at noon today. And we are, again, strongly evaluating the idea of asking them at the end of this week to cease offering Pfizer first doses at their third and final clinic because of the logistical challenges of making sure people can get that second dose 3 weeks later. So I'm very interested in the chat, or if we get to questions on feedback from y'all about that, so that we can understand your perspective on it. I think there's just one more slide. Finally, you'll remember that the Bridge program has two strategies to it. One is to meet those ongoing needs as best we can, and the other is to get the normal long-term care pharmacy infrastructure up and running with the COVID-19 vaccine so that your ongoing needs can continue to be met by your contracted pharmacy partners. The progress is good here. This is good news. For those of you that contract with Omnicare, they are planning to roll out their program by which they will be able to meet your ongoing needs in the first week in April. They are hoping to use the Johnson & Johnson vaccine for this. At the end of the day, they're going to use whatever the CDC will make available to them, and really nothing is certain there until the vaccine is in hand. But they have stated, I spoke with them last week, they have stated that they will have the ability to meet the ongoing needs for their contracted facilities first week in April. If the facility is one in which there's a clinical team that is capable of delivering the vaccine, Omnicare will have the ability to ship and deliver the vaccine to the facility for administration by those clinical staff. In the event that it's a facility, maybe like a group home or another type of facility that does not have a clinical staff, they are working hand in hand with the CVS retail outfits. They will provide a toll-free number for those facilities to utilize where they can schedule a block of appointments at a CVS retail outlet in order to get those needs met. We are working a similar program with Remedy. Again, Remedy is a big long-term care pharmacy partner in Virginia. They are doing some of this work or standing it up in Ohio, and we're replicating here in Virginia. Remedy will be looking to execute agreements with their contracted facilities in the Commonwealth, such that they can deliver the medications on a vial basis to their facilities for administration by those clinical staff. Some of our other partners, Southern Pharmacy Services has 70 long-term care facilities in Virginia. partners, Polaris, Family Care, and some others, have the ability to actually go on site and administer. Even if that's not their normal business model, they've shown a willingness to do that. And so all of this boils down to the fact that come that first week in April, we feel like there's going to be an awful lot of these ongoing needs that can be met through the normal pharmacy infrastructure, and that will continue to grow over time. So there is light at the end of the tunnel with regard to your new hires and new residents that need to start a vaccine series. Do keep in mind that in some cases, these pharmacies will be looking to execute agreements with facilities. Those agreements aren't under the purview of the health department or anything else. I'm just giving you a heads up that those agreements may be coming, and they'll want some attention so that the pharmacies can serve you. The long-term strategy here is for us to enroll the long-term care facilities. That will take 90 to 120 days total, and these measures that will start in the first week in April will provide for your ongoing needs as we complete that enrollment. I encourage you, and even CDC encourages on their long-term care facility page for you to reach out to your long-term care pharmacy and inquire about what their process and pathway to meet your ongoing needs looks like. And if you identify one of your pharmacies that has not spoken to VDH about this, ask them to send me an email. I am happy to work this on your behalf. I want to make sure that every pharmacy, I want to make sure that every long-term care pharmacy in Virginia has some capability to meet the needs for its contracted customers. I believe that that's the end of my slides. Is that right?
Yeah, Craig, a question came in. Is there a specific vaccine that Remedy may get, or is it whatever the CDC allocates?
Yeah, I don't know that answer. I don't believe it's going to be the Pfizer product, just because I want to say when I was speaking with Dale, that one wasn't one they were entertaining. And the allocation scheme for those long-term care pharmacies is dictated by the CDC, and it kind of changes on a week-by-week basis, and we don't have eyes on it. It goes all the way back to manufacturing from the manufacturer and what hits the distribution chain. So you should expect it to be either the Moderna or the Johnson & Johnson product. But I don't have, I wouldn't feel good hazarding a guess as to which it may be.
Okay, well, thank you so much, Craig, for all your hard work on behalf of our members and those we serve. We really appreciate it and appreciate you taking the time to give us these updates today. We don't have any questions in the chat right now, but if they come through, we'll be in touch.
Awesome. Yeah, I may have to jump off and keep calling these facilities that have second dose Pfizer needs, but I truly am interested in feedback around what it means for y'all and your members if we ask CVS and Walgreens to stop offering first doses at their third and final clinic. The decision may get made regardless of what that feedback is, but I believe that hearing from our stakeholders is of critical importance. And so I truly am interested in that feedback. If anybody wants to give it to y'all or email it to me, I'm interested.
Okay, and we're just seeing one come in from Tracy Jennings saying no concerns on her end about CVS and Walgreens. And I think a lot of our members have had most of their clinics. So to our members on the call, you see Craig's email there. And of course, you can always email Dana or I directly, and we can pass that on to Craig. So thanks for wanting to hear from them, Craig. We appreciate it.
Yeah, thanks very much.
Okay, next up, we are delighted to have Michelle Ames, Area Vice President of Pharmacy Services with Pruitt Health, who's going to provide a brief pharmacy perspective on the transition from the long-term care pharmacy program to the vaccine bridge program. And just want to thank Michelle and Pamela Casaboom, who are both with Pruitt Health, and they are a Platinum Elite sponsor of LeadingAge Virginia, and we appreciate their support financially and intellectually. So, Michelle, over to you.
Excellent. Thanks, Melissa. I appreciate you giving us the opportunity to get on here and speak with your members today. I do want to start by giving kudos to Craig and his team at VDH. We cover 5 states, South Atlantic territory from Virginia down to Florida. And I will say of those states, Virginia is the only one that I know of that specifically has a bridge program try to help cover that gap between the long-term care pharmacy enrollment and your clinic format that's been going on as part of that federal partnership. So, like I said, that is something that's unique to Virginia, at least in the territory that we cover. And I really commend them for understanding the needs of the long-term care community. I think we've seen a lot of people out there that don't necessarily understand the specifics of long-term care and try to get this group to fall into a more retail-like bucket. And it's great that your state health department recognizes the difference there and are helping you cover that. So, that said, all states do have very different plans and priorities and processes for getting their pharmacies, enrolled in this vaccine program. And we've pretty much seen it all. Our pharmacy at Pruitt, we've been included in the phase 1A rollout in South Carolina. So, we were lucky enough to be one of the vaccine providers through that clinic format in that particular state. And have been running our own vaccine clinics there. So, it was nice that we were able to service our facilities in South Carolina rather than having CVS or Walgreens come into those. So, that said, we've just kind of been looking for almost any route possible to be a vaccine provider and support our facilities and long-term care centers. And, I know that that same feeling is in place for a lot of my peers at the other long-term care pharmacies that you see out there. So, at Pruitt Health, we are seeking enrollment both at the federal and state level. And I think you'll see that across the board with a lot of pharmacies. So, if you go to the CDC webpage and look up the federal pharmacy partnership, most of the long-term care pharmacies aren't going to be listed by name there. That whole relationship is being mediated by three major group purchasing organizations that, the hundreds of long-term care pharmacies across the country fall into. And so when you go to that list, we in particular work with GeriMed, and they're the ones that are facilitating that enrollment for their pharmacies through the federal government. Again, we continue to work at the state level with the various state health departments, VDH included, to be on that provider list and be able to bridge that gap with vaccines, until we really get to the place where, we're in a greater supply and a structure that looks more like, your typical flu vaccines that can be sent to the facility to manage. But in the meantime, like I said, we are looking for any opportunity that we can to get enrolled in that program. It changes daily. We get updates daily, what that process looks like, what the requirements are going to be. Right now, it looks like through the federal partnership, they are expecting probably early April that pharmacies are going to have vaccines via that mechanism. And again, you heard from Craig, the state health department's working with those long-term care pharmacies to also get them enrolled at the state level for potential allocation that way. So, several mechanisms that are in place that we're trying to get vaccines out to our long-term care facility partners. I know we're anxious to do it, particularly with the outcomes that have come from that. So, if anybody's seen the charts and the graphs out there, the deaths and the positive cases in the long-term care setting in particular are declining at an even greater rate than they are in the general community and the population. And that definitely speaks to the success story that this vaccine is going to be, and hopefully the light at the end of the tunnel for us. So if you haven't had a chance to go look at those rates, I encourage you to check out the CDC website. Take a look at that. We're at the lowest point we've been since prior to last May in long-term care. So that's excellent. I will say your pharmacies are going to be working with you, Pruitt Health included. We don't have a whole lot of creative license in how we run these programs. Everybody's obligated under the CDC provider agreements, and most of the states mirror and mimic those same agreements that we have with the CDC that structures how we run that program and what the pharmacies will do for you. And so, it's in most cases, I think you're going to see a combination of one to two things. Just like Craig mentioned, that either the pharmacies will come in and run that whole program, or they may partner with a facility and set up an administration agreement to work with the facility on the actual administration of the vaccine. So, working with a nurse there to give that dose. And I think that might be the more common route that you see amongst your pharmacies, simply because, rather than relying on a nurse or somebody who's maybe certified to immunize in your state, it'll get people in your facilities quicker with vaccines to have that partnership with the long-term care facilities. So, like I said, that's, I think, going to be a standard part of that program and not something that should take anybody by surprise until we kind of move over to the whole process where the facilities can do the vaccines themselves. The one question I do get a lot that I think comes from maybe some of the American Healthcare Association communications is, it does tell you make sure your pharmacy is registered with the state IIS system. So in Virginia, that's the VIIZ, the VIS system. The one thing I will say is that's guaranteed. If your pharmacies have vaccine, they are going to be registered with that state program. That's one of the requirements of that system. So, if you're worried about your pharmacy being registered or not, if they have vaccine, they're going to be registered with that system. And then lastly, if you are looking to find out if your long-term care pharmacy is on that list, I will reference you back to the ASCAP website, the American Society of Consultant Pharmacists. They have a great listing on there. They have a hot map and a listing of all the pharmacies that are seeking enrollment as a vaccine provider across the country. So, I think it's beyond just the long-term care pharmacies, but that's a great website to reference and refer back to if you're looking for a specific pharmacy in your area that might be part of one of those vaccine programs, in addition to your state resources. So, that said, we're just really excited to be part of this. Like I said, it was exciting times in South Carolina to be part of that phase 1A clinic format. And we're definitely looking forward to providing that same service across all the states we service, Virginia included.
Great, thanks, Michelle. And you'll see that Craig mentioned in the chat that he's been in contact with Weston and Durham to bring you all into the program. So I know that your providers will appreciate that. Thanks for being here. We appreciate your support. We're going to go ahead and move on to Jody at LeadingAge National. Jody, I know you haven't been working at all this year. This past year, you've been sitting around with your feet up.
I know. It's been living the good life, right?
And seriously, we're so we so appreciate the work of you and your whole team at National. So thanks for being here today. I will turn it over to you.
Thank you. And I have to tell you guys, in addition to living the good life for the past year, I'm also living the good life today where I am on my third computer of the morning. I don't know what is going on with technology in my household today, but it is like, I'm glad to be here because I wasn't sure I was going to be. So,
well, we're glad it worked out and impressed that you have 3 computers to choose from.
Oh, you don't even know. I had my laptop that wasn't working. I don't know what it's doing. So I went to my husband's desktop and I couldn't get any sound on there. So now I found this really old laptop that he brought home to give to my daughter to play video, like little ABC games on. And so glad to be here. So we're going to talk about CMS guidance, and I have linked it in your slide today. This is the visitation guidance that just came out. And one note, if you are going to look for this on the CMS site where they post their policy memos and things, note that it's a revised memo. It's not its own fresh new memo. And so as time goes on, it might get buried down under the original September date. So I just want to make sure everyone's aware of this. This is the September guidance that came out, and they have revised it. So that's the new memo. I'm going to talk about first what doesn't change. So here's the things that do not change between the new memo and what was put out in September. Outdoor visitation doesn't change. You're still doing outdoor visitation. It is still the method that is preferred for visitation. Compassionate care visits, that doesn't change. You're still permitted and encouraged to do compassionate care visits for all residents in the nursing home where a compassionate care visit would be appropriate. No visits for anybody who's on transmission-based precautions, with, of course, compassionate care visits being the one exception. So whether it's an outdoor visit, whether it's an indoor visit, nobody on transmission-based precautions can participate until transmission-based precautions have been discontinued. Access to the ombudsman doesn't change. You still need to be permitting access to the ombudsman if an in-person visit is not available for whatever reason, like maybe the resident is on transmission-based precautions. In that case, you need to be assisting the resident with, virtual visits, telephone calls, that sort of thing. And then, of course, visitor screening does not change either. You still need to be screening anybody who's coming into your building for symptoms, for exposure, and then restricting as needed. One thing I will note on the restrictions, though, similar to the way that you are not permitted, at least at the federal level, to restrict a visitor based on a lack of a test result. Like, you can ask for a test, you can offer a test, but if they don't have a test result, you can't restrict that person. It's going to be the same with vaccination. You could ask your visitor for a proof of vaccination, but you cannot restrict a visitor because they don't have proof of vaccination. Next slide, please. Thank you. So here's what does change with indoor visitation. Indoor visitation should be permitted, CMS says, for all residents at all times, but there are some exceptions. So, of course, residents on transmission-based precautions, they are not permitted to visit regardless of their vaccination status. So even if they are fully vaccinated, if they are on transmission-based precautions, no indoor visits, no outdoor visits. For unvaccinated residents, they should be permitted to do indoor visitation except when the county positivity rate is greater than 10% and the total number of residents in your community who have been vaccinated is less than 70%. And I got a question about this the other day saying, well, does this, if I'm a multi-site organization, is it my one setting or is it my entire organization? And CMS has not been that specific, but based on what we do know about the intent of this guidance, they're looking at that 70% as herd immunity. And so that leads us to believe that they're talking about your single site. If 70% of the residents who are on site at that community have been vaccinated, then you can allow unvaccinated residents to have visitation. Next slide. Here's what changes with indoor visitation during an outbreak. So you've got an outbreak. Remember that that is identified as one case among one case among staff, or one new nursing home onset case among residents. Residents who are admitted with COVID-19 or residents who develop COVID-19 during that 14-day observation period are not considered new nursing home onset. But if you identify an outbreak, you have to suspend all visitation until you have completed one round of outbreak testing. So you identify your case, you suspend visitation, you test all residents and all staff in the nursing home. If that initial round of outbreak testing shows that the outbreak is contained, then you would resume visitation for the unaffected areas. You would continue testing everybody, all residents and all staff, and you would notify any visitors in those unaffected areas that, hey, we have an outbreak going on and you are at greater risk if you're visiting during an outbreak. If that initial round of testing shows that that the outbreak is not contained, or if any subsequent rounds of testing show that there has been spread, so your first round shows that you had 3 cases, but they were all on Unit A, but then the next round of testing shows that you've got 2 cases that pop up on Unit B, then you suspend visitation for all areas of your community, of your nursing home, until outbreak testing has been complete, meaning that everyone tests negative and it's been 14 days since your last positive. The question about contained is the tricky question here. A lot of people have emailed us questions over the past few days since this visitation came out saying, how do I determine if it's contained? Like, what if I have cases that are among staff, but I have no cases among residents? And what if I have a COVID unit that's on a wing that's shared with a non-COVID unit, but the COVID unit is like completely sealed off? CMS is not getting very detailed about that. And though we do expect more FAQs to be coming out and more information to be coming out soon, soon being hopefully in the next few weeks, to provide a little bit more clarity, they're not going to get that detailed. They like to try not to be detailed because they want people to be able to look at the big picture and make the best decision. Of course, we all know that that's really tricky, right? Because everybody has a different interpretation, and you might interpret things one way and the state survey agency might interpret it the other way, but the intent is containment. And so look at the big picture and look at if it is contained. Is it you have 3 staff members and they're all on the same department, or maybe they're all working in the same area, so you can say, yes, all right, it is contained to this area where they're working, and we can proceed forward in that way. You can go to the next slide now. Thank you. The second thing that kind of pairs along with that, CDC put out guidance on the exact same day, updated healthcare infection prevention and control recommendations. I have also linked that here in your slides. The part about visitation is consistent with CMS guidance. And I'll note, so they have titled this very interestingly, healthcare infection prevention. What they mean by healthcare settings is nursing homes and assisted living specifically. And when it comes to our other LeadingAge member settings, CDC says you could follow general public health recommendations, or you could follow the healthcare recommendations, healthcare settings. The way you would make that determination is really looking at what's going on in your community, what types of individuals you're serving, what their underlying health status and comorbidities might be, and what those risk factors, how they all shake out. So your visitation is consistent with the CMS guidance. They did put in some changes around quarantine and work restrictions. So CDC is no longer recommending that healthcare personnel who are fully vaccinated and have a high risk exposure be restricted from work. Previously, if it was a high risk exposure, you needed to be restricted from work. CDC now says as long as you don't have symptoms and you are fully vaccinated, you are okay to go ahead and work. They are also saying that fully vaccinated residents who have had, who are being admitted to the nursing home or being readmitted to the nursing home no longer need to quarantine upon admission for that 14-day period. They can just go ahead onto into their regular rooms or onto a regular unit. So that has brought up a lot of questions. And we tried to cover those with CMS last night, and we really didn't get very far in terms of clarity. CMS is going back to CDC, and they're going to be talking with CDC a little bit more so that we can get some more information about how does this work out for non-vaccinated residents? How does this work out with the other CDC guidance that says people need to quarantine on admission, and even if they test negative, they still should be under observation for 14 days because a negative test could turn into a positive test, and all of that. So I guess all of that to say that CMS and CDC and all of us, we are all kind of trying to work this out as best we can. And we are grateful that CMS and CDC are listening to us when we say this is not enough information. We need more. We need to know a little bit more definitively how to handle these situations. Next slide. And so then the last thing I wanted to talk with you guys about, you probably heard about our Care for Our Seniors Act and reform proposal that came out this week. This is a joint venture with the American Healthcare Association. And we are proposing reforms in 4 key areas of nursing home functioning, and that's clinical, workforce, oversight, and structural. So when it comes to clinical improvements, we want to enhance the quality of care, and we have proposed a few different ways of doing this. One of them would be a 24-hour RN on-site requirement. Infection preventionist, increased time for the infection preventionist, and this would really be determined. How much time you need with that infection preventionist would be determined by things like your bed capacity and what's going on in your community and what's going on in the community outside of your nursing home, and then a 30-day supply of PPE to make sure that we don't run into the hardships that we ran into at the beginning of the pandemic and that we have had crop up at different times. Workforce, we want to strengthen and support our frontline caregivers. We're focusing mainly on recruitment and retention strategies like maybe loan forgiveness, tax credits, housing, and childcare support. Under oversight, we want to improve systems to make the survey process more resident driven. So improving that survey process to be not focused on the punitive aspects, but actually focused on improving quality of care, addressing poor performers more effectively and more efficiently to either help turn that around or help get the poor performers out of the game so that residents can get the care that they deserve, and then including customer satisfaction and the 5-star rating. And then lastly, with structural reforms, we want to modernize for resident dignity and safety. And so one of the ways that we would be doing that is calling for a national study that would investigate costs and approaches to shifting to private rooms. We know that it's a big undertaking, but we know that private rooms not only enhance the dignity for residents, but that it also helps improve with infection control, as we have seen over the past year and even before the COVID pandemic. And so it's ambitious, right? But I think that the bottom line is we all want better care for residents. We all want nursing homes to be better places to live and to work. And we know that this is going to take money, right? And so, along with these reform proposals, we have also proposed different ways that government resources can help fund these reforms at both the federal and the state level. And the more information about this proposal is on our website. And so I don't have the link today because of the 14 different computers that I've been on, but it is on the LeadingAge website, so you can check it out there. And that's it for me.
I will post the link in the chat in just a second. In the meantime, you have a few questions that have come in the chat, Jody. The first, a couple of them are long, so maybe I should direct you to the chat.
Sounds good. Let me pull that up.
Yeah, the first one comes from Rebecca at 1127. Hers is not one of the long ones. Do you see that one?
Yes. In efforts to help guide and direct visitation with the core principles of infection control, talking about the age limit on indoor visits. Yep. And so that is a question that we get a lot. And especially recently, this question has come up a lot about how do we handle children visiting. So, and I have heard people asking about, can we put an age limit on visits? I think that there are probably communities out there that are putting limits on that. I have not heard yet how that plays out when it comes to survey. I would say that each visitor is going to be a little bit different. And their abilities are going to be a little bit different. And so children maybe have a little bit of a harder time and adhering to those core infection control principles, and the age of the child is going to be different, right? Like I have a daughter who's almost 5, and she is awesome at wearing a mask, right? Like so good at it that she calls people out on the street when they are not wearing it, which is something that we need to, address with her separately. But she's really, really good at wearing a mask. But when it comes to limiting the surfaces that she's touching, she's not so great at that. We have also heard that in schools, younger children, again, really, really good with the mask. When they get up to teenagers, not so good at the masks. They don't want to wear them. They're pulling them down. They're exposing their noses, that sort of thing. But on the flip side, the teenagers are probably a lot better at keeping their hands to themselves and practicing hand hygiene and things like that. And so I think that it is something you could consider as a community. If you're going to go that route, you'll just want to make sure that it is a very thought out plan, that you are clear and transparent in your thinking and in documenting that process, because not only are there going to be a lot of questions from residents and families, but of course you want to be able to demonstrate when a surveyor comes in your building that you weren't just making decisions blindly.
Jody, I just wanted to say two things. One, teenagers are good at keeping their hands to themselves because they're on their phones the whole time. But I do see that Michael posted in the chat that they have an age limit of under 18. And while there is some pushback, most all have understood, particularly in the nursing and assisted areas. Recognizing that comment. And then your next question is, if you go down a little bit, from Nathan.
Mm-hmm. Okay. Would we be in compliance with the new guidance if we are offering indoor visitation for residents in designated areas and by appointment only for a certain amount of time? Visits would include plexiglass barriers and yes. So Let me read this silently for a second to make sure I'm understanding. Okay. So I think if I'm understanding correctly, Nathan, you're asking if indoor visitation can still be between plexiglass barriers and can you still limit the amount of time and that sort of thing. And the answer to that is yes, you can do all of those things. Those are included in those core infection control principles. And so you you do want to, again, like with the children's scenario, you do want to make sure that you are able to back up any decisions that you're making and to explain why you have made these decisions. But CMS has said you need to look at what's going on and you need to be able to make those decisions within your community in a way that keeps everybody safe. And if that means that you're limiting the amount of time that people can visit and limiting the numbers of visitors, if you've got concerns about community spread, it may be still including those plexiglass barriers. One thing that I will remind everybody though, if you've got high vaccination rates in your community, like the majority of your residents are vaccinated, or you're looking at one specific scenario where you have a vaccinated resident and the visitor is unvaccinated, remember that actually the visitor is the one who's at risk, right? Because they're the one who is not vaccinated, and so it you have to kind of keep that in mind with what risk that visitor is willing to take on, um, because the resident, presumably, because they have been vaccinated, either will be protected against the virus or will be protected against severe illness from the virus. And so, so you do need to keep that in mind when it comes to the question of being restrictive. But it's certainly, we're all very wary of this. And I will note that we had a lot of questions about activities and dining and things like that. And when we were talking with CMS about it yesterday, I kind of had this moment of like, oh, holy cow, I've been looking at this from the wrong angle. We've been looking at this guidance as visitation, and CMS was looking at it as, yes, we're specifically addressing visitation, but our intent is that you are getting back to the way life was. Not, you're not 100% there, but you're making your way closer back to that by simply modifying activities within the core infection control principles. And so you're having visitors with those core principles of infection control, and you're having residents going out on outings. They said that residents can do that. They can go out to visit family, but they need to adhere to those core infection control principles while they're doing it. You can have a musician come in and play some songs for the residents as long as they're adhering to those core infection control principles.
Okay, Jody, I think, let's see. Did that cover all of Nathan's?
I believe so.
Okay.
Nathan, if we have not addressed your question, please let us know.
And then next is Michelle.
Yeah, so monitoring of visits versus supervised visits to ensure that core principles are being adhered to. So, first, I'm not sure if states have, I don't know if Virginia is requiring supervised visits, but CMS is very clear that they do not require supervision of visits. I think that they are very concerned about the privacy aspect of that. The residents deserve they have the right to privacy for their visits and for their interactions and things like that. And so CMS has said, we don't require visits. You do, of course, want to be sure that you are, for example, at the screening station, you're screening for the symptoms, you're making sure that the visitor is performing hand hygiene and you're providing information to them at that time, like here's how you practice hand hygiene. Please, when you're in the residence room, limit the surfaces that are touched. If you are choosing to have physical contact, like if the resident is fully vaccinated and the resident permits physical contact during the visit. Here's the way that that needs to be done. You need to do hand hygiene before, you need to do hand hygiene after. Everybody needs to keep a mask on throughout the visit. All of that kind of instructional information, and either escorting them to and from the visiting space, or you have clearly documented signage and things like that. That's kind of CMS's expectation for how you can make sure that those visits are adhering to the core principles. But CMS's expectation is not that you're standing there watching those visits. This is as we like to say, this is not prison, right? So we are not monitoring those visits and shouting at people for like getting too close and things like that. You have to do the work on the upfront part of it and then let the resident have their privacy.
Great. And I see that Nathan put a follow-up into the chat box as well.
Okay, let me scroll down for that. 11:43, right?
Yep.
Okay. Yep, this is about quarantine. So there's a lot of confusion. So I'll start with, as Nathan has stated here, the CDC guidance had said you definitely have to, in CMS as well, said you got to have a positive unit, COVID-19 positive unit, and you should have a COVID negative space, of course, and you should have a space for observation. And this is what CMS calls COVID unknown, but CDC had not been calling it out that specifically to say that unknown status. This is a space where people are quarantined for 14 days after admission or readmission. This is the space where that's basically the people that are in that observation space, because if a resident's on the negative unit and they develop symptoms, you're not supposed to move into that observation space. So you've got that observation space for the 14 days of admission, after admission. And CDC guidance for nursing homes, which came out months ago, said that when you put somebody on that observation unit, even if you test them, even if they test negative, they really shouldn't come off of that unit for 14 days, because a negative test prior to admission or a negative test on day 1 could turn into a positive test on day 5 or day 10 or day 13. And so they need to be there until 14 days have passed. On day 14, if you want to test them just to be sure before you put them out in your COVID negative unit, you could go ahead and do that. So that's what we've been working under. And then this new guidance just came out saying, well, for fully vaccinated people, you don't have to put them in that observation space. And this has created a lot of questions for us that we have brought to CDC and CMS, and that we hope that there will be more guidance coming on, because the questions that we have heard is, well, I am fully vaccinated and I'm not showing symptoms at all, but maybe I am an asymptomatic carrier of that virus, and you have now just put me into the COVID negative space where there might be unvaccinated people. So we're concerned about that. CMS is concerned about that now that we have brought to their attention. CDC, I'm sure, is concerned as well. And so we are looking for follow-up on that. We just don't have the clear answer at this point. So at this point, we are still following the CDC guidance of fully vaccinated, do not have to quarantine. Unvaccinated should be quarantining for 14 days.
Excellent. Jody, I don't know what we would do without you. Thank you so much. I'm going to give it one more minute for the chat and see if anybody has any other questions, or if you want to come off mute and ask, you're more than welcome to do that. I also put in the chat for our provider members that our call for participation should be in your email inbox. And there are lots of ways to serve through different cabinets, councils, work groups of the association, including a new one that we've called the Future of Long-Term Care Learning Circle, which we're taking a cue from LeadingAge National, and we want to have some of those conversations on the state level. So please access that call for participation link, and we hope that you'll volunteer your time. It takes all of these great minds to help us think through some of these big issues. I don't see any other questions that have come through, so I want to thank all of our speakers for being here today. Our next call is tentatively scheduled for March 24th. You know that we schedule them as things come up that we know you need support on. So anything happens in the meantime, please reach out to Dana or myself. We're only an email away. And we want to thank you all for being here, and thank you for your continued membership with LeadingAge Virginia. Happy St. Patrick's Day. Go get something green. Take care, everybody.